So if I could welcome Amanda and Nitin to your first formal board meeting, you're very welcome. I know you've been at some other meetings over the last couple of weeks, but it's good to see you here today. And who knows, we may even meet physically one day. There's always that chance, but at the moment we're meeting like this.
Thank you.
In terms of my introduction, I suppose Sam and I have had a number of conversations recently about what the sort of task is for the board, and in some ways I think we've been reflecting, and I know the team have been reflecting as well, that we're actually entering in some ways what could be an even more difficult period than the one we've just been in, and we'll talk about that through the meeting, in that we have to carry on managing the ongoing pandemic. We need to prepare for a potential increase in demand, particularly for crisis and emergency care, but also for other demand across the system, both from our existing patients and from new patients who may have become mentally ill through this period. We need to respond to the needs of staff, and this morning we'll be discussing some of the specific issues that are coming up, but we need to recognise that actually supporting and sustaining our staff is going to continue to be just as important over the next months as it has been over the last weeks. And we need to respond to population mental health, that we need to recognise that there's going to be trauma out in the population, there's going to be ongoing need developing in the population, and that will both be in terms of the response, if you like, to the pandemic and the economic and social impact of the pandemic. So we have quite a significant task ahead of us as the specialist mental health provider for Sussex. And I think that part of the board's role is going to be to sequence those conversations in a way that's manageable and realistic, but also I think even more than it is normally, to be very clear what we as an organisation are going to try and do and what we're not going to try and do. What are the things that we are going to focus on? Because I suspect that the demand is going to be huge, and we're going to have to be very clear as an organisation what we can and can't do. And that's something I know that Sam will be picking up later in the meeting. But I think we as a board, particularly between now and our next meeting, need to work with the executive and support the executive and the senior staff across the organisation to be very clear about that messaging and how we're going to respond as an organisation. So some themes to pick up there today. That's my introduction. Can I now move to apologies for absence? I'm not aware of any apologies, Dom.
No apologies, Peter.
No apologies. Declarations of interest, any declarations of interest that haven't previously been declared that are relevant to today's discussion?
None.
Okay.
No.
Karen, we haven't had any questions from members of the public submitted, so we don't need to look at that today. So in terms of the chair's report, I will take this as read. I mean, I think one of the things that's been really interesting is the work that's going on between mental health chairs across both the region and nationally to try and make sure that we're, one, learning from each other, but also in terms of making sure that we're continuing to amplify the voice of mental health alongside our chief execs. There is something here, I think, particularly around COVID-19 and inequality, and that's something that we've been very concerned about, and I know Sam will pick up on that. But also, as I alluded to in my introduction, starting to talk to the leaders of the local authorities about the economic and social impact on population mental health, and starting to get a feel for how the local authorities are wanting to respond to what will be a significant economic challenge, and how we as an organisation can help with that to the extent that it's appropriate. So those were the themes that I wanted to pull out. I'm happy to take any questions if people have them. No, okay, thank you.
Well, Peter, I wondered if I could make a point. I hope not to ramble too much, but sorry, shall I carry on?
Yes, please do, yes.
Yeah. So when we're talking about the population health and population mental health, there's just two things I think we should be thinking about. And the first one is language. That in the coming period, we're likely to meet many people who need our support, who've experiencing mental distress or put the mental ill health in the context of well-being. So I think there's a piece of work to do, which I'm sure Nick Lake is more than aware of, around the language that we're going to be using. But if we do use, for now, the language of population mental health, I think we have to start also revising our language around the voice of experience and actually population voice. And because of the inequity of how the population has been impacted by COVID-19, it yet again brings the whole point of service user led, service users' voices, the voice of lived experience into the equalities agenda, and the equalities agenda and the ability to hear the voices of people from our population, marginalised or otherwise, who are experiencing distress. It starts to bring that back on our agenda, and the role of listening is critical, really, and it's very important at a governance level, right throughout the organisation, not just through patient story, but through the governors, that we start to have a much more sharp and aware way of listening to what's going on in the population, using that and using that very positively at policy level to steer and direct us. So I just wanted to talk a little bit about how my language is changing from the internal voice of service users and the external voice. It's changing now to the voice of lived experience, or the voice of the population, with specific reference to those who are marginalised. And I think it's very timely for us to say, what are we not going to provide, because it can be provided better elsewhere. So that's all the thoughts that came up when I read your report. Thank you, Peter.
Okay, thank you very much, Anne. Well, I think we can pick some of that up when Nick talks about the work that the Trust is doing under the Chief Exec's report, and I think that's timely. I think you're absolutely right to bring up the points about language, and I suppose I was using population mental health in a slightly jargonistic way here, and it's right to challenge that that's not always appropriate. Talking to the lead governor, the governors would be keen to have a task and finish group looking at how we engage with our population, and I'm very keen to set that in the context of the work that Akosia and Liz are doing between now and September on the patient PPI strategy. So I think those are all three a very valid challenge, which I accept, and then two good points which we'll pick up later in this meeting and between meetings around how we might tie the governors into the work that's going on in the development of the strategy between now and September. Is that all right?
Thank you very much.
Thank you very much.
And okay. Peter,
yes,
Peter, very briefly, again, not for now maybe, but for further down the line, really interested in the use of hubs, which you talk about in your report, and I think maybe a little bit more detail of what that will entail and how that's going to work would be helpful for me, because it sounds as if it's the right approach.
Okay, great. Thank you very much. We can pick that up as well under Sam's report, I think.
Sure.
Thanks, Martin. Okay, can I move us on, please? So, Chief Executive.
Thank you, Chair. So again, I'll take the report as read. I just want to go through and cover a few things in here, though. So firstly, you'll have seen that there are 4 attachments to the report. We've got the update in terms of the approach we're taking around mental health resilience and recovery planning across the Sussex Health and Care Partnership, and that has been led by our Clinical Director of Strategy, Nick Lake, and Nick will certainly come in and say a bit more about that as well. We've got the integrated care system Sussex response to what's being called second phase that we're moving into in this level 4 major incident and responding to the pandemic. And Simon, our Chief Operating Officer, who's our Silver Tactical Commander, is leading that. And that response predominantly focuses around the immediate actions within the organisation around areas like crisis and urgent care, our critical services, access, children and young people. So it's very much the tactical and operational response as we move through this second phase. We then, for the report, the board today, have included a more detailed report that gives you an understanding of the Clinical and Professional Advisory Committee, and as part of that, the Ethical Decision Making Group and the processes that have been set up there. That has been led by our Chief Medical Officer, working closely with our Chief Nursing Officer and colleagues, and reports into our Gold Command structure. This has been a really critical part of the way in which we've been taking decisions through our response to this major incident. And the paper doesn't just set out the process, it gives you an overview of the type of issues that we, the practice issues, the legal issues that we've been considering in our operational response to inform practice guidance across the organisation. And again, colleagues will want to add to that. And then finally, I appended a summary that sets out the collaborative work that we've been undertaking as an organisation with 2 other mental health and learning disability trusts, Northamptonshire and Leicestershire, up in the Midlands. And this has been really quite instrumental in informing our approach as an organisation to the work we've been doing around support and the risk assessment of our BAME staff. And yesterday I was really pleased that the chair and Joe Larby, one of our executive directors, joined myself and members of the executive team and the chair of our BAME network more detailed and thorough review of work underway far. The primary objective, quite rightly, has been responding to the risks that BAME workforce and BAME communities face with regard to COVID-19. I think it'd be fair to say that this is, I think, something we're seeing as a real opportunity to really review and I think accelerate our whole work around inclusion and diversity. I think one of the things that we absolutely need to do is to look more broadly across our population around other groups where they experienced health inequalities and some targeted work there. Also, I wanted to put a particular spotlight today on people with a learning disability and autism and work of our care delivery service, from our inpatient service right into our community services, and this child nicely as well with the patient story that we've had today. This is a really, really important part of trust business. It's a relatively small part in comparison to other areas and perhaps doesn't always get the airtime that it certainly needs and deserves. And we've been very mindful throughout this major incident of the support to our learning disability care service, predominantly because of the increased risks that client group do face. And the report does touch on, I think, the extraordinary length that our colleagues come to both protect nurse and care clients. And there have been moments in the past few, it has been incredibly touch and go for some of our clients, and I have no doubt that without their compassion, their passion and their sheer dedication, the outcome may have been different for some of those clients. So certainly something we wanted to put the spotlight on today. And then the report also touches on the Care Quality Commission, who have been issuing some guidance over the last couple of weeks, particularly around areas that we need to be really mindful of in terms of restrictive practices, and indeed really making sure that we're responding appropriately to high risk groups. Before I open it up, Peter, because it would be helpful for some of the other executive and colleagues to come in on particular areas. Because just sort of one final thing I wanted to say, because we are considering our risk appetite as a board and on in our agenda today, and obviously that's linked into our board assurance framework. And at the end of 1920, we approved our business plan, this year operating plan, and our strategic priorities. It's clear, goes without saying, that the environment has changed significantly over recent weeks, and given the implications of the pandemic that you touched on, Peter, in your opening introduction to the board today, we, in this phase that the NHS is calling Reset and Recovery, we, I think, as a mental health learning disability provider, are going to have to take on an incredibly critical role across the health and care system in responding to what inevitably will be an increase in demand and prevalence of mental health difficulties in the community, and ensuring that we take a real mind and body approach around building resilience. There is a real risk that some of what communities are and will experience over the coming weeks and months could potentially become over-minimized. That's not something that we want to do. We want to build on efforts that exist in our communities, and your point about what shouldn't we be doing, what do we need to do more in partnership, and that is the very, very basis of the resilience plan that has led the development of, but inevitably creates a different operating environment, a different set of strategic risks for us, that through looking at our risk appetite, and I work with plan month, Peter, for board development, we will need to go back and revisit our breakthrough objectives that we set this year and our strategic priorities as well. But what I'd like to do now, well, one just final thing, Peter, if we can come back to it at the end, there is one recommendation in my paper and our BAME work statement, and it would be good to come back to that. I'd
Sure.
like to Nick, who a bit more about resilience planning. That's
so what I want to do is I want to give people a chance to ask you any questions they've got on the report you've just given. Then I'd like to come to Rick to talk about the Professional Clinical Advisory Group, and then I'd like to come to Nick to talk about the Resilience and Recovery Plan. Does that sound okay as a plan? Sam, have I missed anything? That's fine. So any questions for Sam before we go to Rick and Nick?
Peter.
So Gordon first, please.
So thank you, Sam. That was the papers are really detailed and I think provide an insight into the enormously detailed planning that's gone ahead. I wanted to mention this issue about the second peak and the potential for that in September, which I think is being planned for in some sectors. And also, I think you've already mentioned this pent-up demand, which will drive an increased service, I suppose, demand over the next few months. But also an issue around support. So the impact on frontline healthcare workers is likely to be enormous, and the psychological impact is going to be great. And what we, as I suppose a systems leader in mental health, are going to do in terms of supporting the staff of the acute trust, care homes, and so on. What are we going to do in terms of providing leadership for that?
That's a great question, Gordon, a really important one. We do know that our frontline health and care workers are certainly at high risk. They're a high risk group anyway, but with the trauma and the challenges that they're facing in their working environments, it's really important that we put in the right level of support to prevent mental ill health. And the really good news there is that our psychology and psychological therapy services have been incredibly proactive in this. And for the last several weeks, they've been assigned to work with our acute trusts. They've been in the organisations. We've been supporting both staff working on the front line, but also patients with COVID-19 as they move through their recovery, also families, because and again, this is picked up as part of the broader resilience plan that Nick has put down. Absolutely one of the areas of priority and focus for us. We have been engaging through the integrated care system in a broader support that's been developed for care homes. That is under development at the moment, and 24/7 health line that we've publicised and made widely available is available for everybody in our population, patients, families, carers, and also people working in our services.
Thanks. Anna, please.
So, I mean, Sam, as you might expect, I mean, I was really pleased to see, you know, the light shone on you know, learning disabilities and autism services, because I think you're absolutely right. The way you've captured this is, you know, above and beyond, you know, and real, you know, sense of just how deeply, you know, the staff at Selden have cared for, you know, in really difficult circumstances. So I was just really pleased to see that. And I also was on a webcam. The RSM did a session on the equity challenge and COVID and people with intellectual disabilities. And I have to say that, you know, all the points that they were making, you know, about what needs to happen, I think are reflected in what the Trust is doing. I mean, there was nothing there that I thought, gosh, we aren't doing that and we should be. So I suppose some key things around it, the importance of ensuring physical health. We talked already about the support for carers who may be in fact more risk averse and maybe shielding their children now because of COVID and all the tensions that arise from that. And then the other thing was just that sense of, you know, the importance of sharing materials, you know, accessible materials that really, you know, will make a difference. And I think we're doing all of that. I think there are a few more things that are out there nationally that Sheila Hollins and others have produced. You know, the Beyond Words series, they've got something specifically on COVID. The Grab and Go guide from the NHS is also, you know, really good. But I just got a sense of, you know, if you kind of want to have a sense of validating what's going on here, you know, it's just fantastic work, and it's all about the individual. And I just wanted to commend it, really.
Thanks, Anna. Anne.
Yeah, it's a very small point that offers an insight into the leadership currently that SPFT is providing. It's an insight into innovation, and it's one of the most touching things I've seen in a long time, is that in learning disability services now, they're giving sensory prescriptions. How fantastic. It almost brought a tear to my eye. And wouldn't it be lovely if we could, Nick and Rick can go on and say how they're going to provide sensory prescriptions in the forms of enabling people to have a hug in their strategy. Just really good piece of work.
Thanks.
Yeah, and hopefully that funding for the evaluation will come about, because that's such an important area, isn't it?
It's just, it really is truly fantastic. And on an anecdotal level, I've heard of staff working in the acute sector who are actually very jealous of the staff who work in SPFT, because the support they're getting, the understanding, the leadership, the clarity, it's, you know, without boasting, because I don't like spin and all the rest of it, but just that tiny example of sensory prescriptions, it just for me touched the heart of how really good SPFT is doing, and in learning disability services and elsewhere.
Fantastic. Yes, thank you. Thanks, Anne. So I just want to move us on to Rick, Nick, and also Dan wanted to come in on the comms piece as well. So well, if we could whip our way through those. Rick, I mean, you're we asked that the board just have oversight of the work that the Professional Clinical Advisory Group is doing, and that's been done through the Quality Committee. I suppose the question for us is, how are we tracking any potential unintended consequences in terms of inequalities, one, and two, how are we ensuring that we're still providing care in the least restrictive environment and in the least restrictive way? But there may be others that you want to flag up for us.
But thanks, Peter. And I'll point everyone towards the appendix, which is in Sam's report, which covers the governance around CPAC and the ethical decision-making group. Just to remind people, the CPAC, the Clinical Professional Advisory Committee, is made up of about 18 of our senior clinicians and clinical managers. And the attendance to that meeting, it started at twice a week. It's now on once a week, and it's been phenomenal. The engagement and the attention to that meeting, I think, has been really, really good. So that shows that from our senior clinicians' point of view, the meeting itself is really fit for purpose. It's being really well chaired by one of our new medical directors, Claire Woolcock, and she's ably supported by Liz Holland in that process. And so the meeting is I think, really working well. It's interfacing with Gold IMT, from where the questions essentially come into CPAC, who would then review new proposals or questions around either service development or, as you say, making sure that we're practicing least restrictive and most, and within current guidelines and legislation. There's still occasionally some issues that we sometimes need to iron out around that interface, because it's actually a really rapid turnaround. So the CPAC at the moment meets once a week on a Tuesday, reports back into Gold IMT on a Wednesday morning. So that responsiveness is really important. And sometimes one of the potential unintended consequences of that rapid turnaround is that specific issues might not get properly transmitted. But as Gold commanders, we're all over that and really making sure that we nurture the group, because actually what we want from CPAC is that they take a wide view, that it's inclusive of all the people joining the meeting, that also they're using those pillars of the governance framework outlined in the paper, and also running through each of those questions to make sure that any decisions aren't actually having unintended consequences. The meeting needs to be agile, responsive, fit for purpose, but also take an approach that it's good enough, because what we don't want to do is for the meeting to get caught up in becoming paralyzed because they can't make a decision because they want the decision to be perfect. And once we set that scene and say to our clinicians in the meeting, and actually more broadly as well, about taking that approach of it's good enough, and then we can, if we get things not quite right, we can make changes, and that's okay. And I think people are really embracing that approach. The ethical decision-making group comes from the Clinical Professional Advisory Committee, and they were meeting twice a day, or at least having slots for people to book into twice a day. The amount of traffic or the demand on that group has been such that they've reduced now to once daily calls. Again, the input and the commitment to that group has been phenomenal, and the three members who are on call each day for that group include a senior medic, senior member of nursing staff, and senior from the MDT, so it might be allied health professional or other psychologist or other professional. And again, the input and commitment to that meeting from our senior clinicians has been phenomenal. People are really, really up for this. There's an out of hours rota as well, which essentially devolves to the director on call, consultant on call, and lead nurse. And if needed, there's someone backing that up from a medical directorate on call rota. So I think that we've got a robust system in place to deal with difficult decisions as and when they come up. There's some examples in the paper of the sorts of decisions that the ethical decision-making group has made, and also an example of some of the papers and proposals that the CPAC has looked at. And when we set the group up, we were expecting that there may be difficult decisions around staff needing the support of the ethical decision-making group around whether or not someone potentially could be referred into an acute hospital for an episode of care, perhaps in the intensive care unit, and perhaps even ventilated. And we were preparing for a system that might be potentially overwhelmed by demand. That didn't happen. So our ICUs didn't get overwhelmed. We didn't have to use the ethical decision-making group for those kind of decisions, thankfully. But there have been some other really interesting decisions around perhaps, as you said, Peter, restrictive, potentially restrictive or least restrictive practice options. And those, all the decisions in ethical decision-making group, they get periodically reviewed in the CPAC, and the CPAC reports directly into GOLD, and CPAC will be providing updates periodically for the quality committee. So that's the kind of an overview of the system, which I think has worked really well. A few little, as I said, issues to be ironed out, but again, that's to be expected because it's only been running since the end of March.
Rick, that's really helpful. And I think both in terms of how it's working, but also how we're reviewing and evaluating as we go along. So I think that commands a lot of confidence. Thank you. Does anyone have any questions for Rick?
Yeah, Peter, just one really. I mean, I'm also pleased that there will be a feed into the quality committee and review. The question, I suppose, is that there will be decisions out of hours, and I wonder what training colleagues might need in making those decisions. I mean, some of those decisions are really going to be difficult. And I just wondered what support there might be in terms of development for those members of staff.
Yeah, so good question, Gordon. I mean, the guidance that we've currently got for our out of hours director on call, consultants on call, and lead nurse, we've got at the end of the paper, you'll see there's a sort of an algorithm to help them. There's also through the pro forma for ethical decision making group, there's a set of key questions that they need to look at and prepare for in their presentation or discussion in the group. Out of hours, the responsibility for forming that ethical decision-making group lies with the director on call to then bring together a teleconference or a Skype with the locality consultant on call and the locality lead nurse. So the decision-making devolves to that group. As to specific training for those people, we haven't yet put into place specific training. We've relied upon the algorithm to guide the decisions, and then also the seniority of those people who are involved in the on-call, who they would together be able to solve a problem and get the, you know, as I said earlier, the good enough response, something that is a decision that can allow things to progress, that then that decision would be reviewed the next day by the leads for the CPAC and myself, so we can make sure that there weren't any issues that needed to be looked at. And just to mention, we've also got the facility to involve our legal department as well. If it's a daytime call and it's appropriate, they've said they could be on call to join the ethical decision-making group. If it happens out of hours, then that could be reviewed the next day at the earliest opportunity. And then as the final kind of backstop, we've got our medical directorate on-call rota, and certainly all of the medical directorate who are in that on-call rota are well versed in the aspects of the ethical decision-making process.
Okay, thank you. Any other questions?
Peter,
Oh, Rick,
just one point to add to everything that Rick set out there, Gordon, just to say that all members of the Clinical Professional Advisory Group have had training through medico-legal services in relation to some of that ethical decision making, and they are the group and the clinical leaders that have developed the framework specifically for use out of hours, so it is informed by that. But I think it's a good point to think about, Rick, whether we roll that out more broadly to some of the lead nurses.
Okay.
Yeah,
and it was an excellent training, actually. Yeah.
And I suppose I'd only just add, Peter, just that I can think of, you know, when I've been director on call, where we've had some real examples where we've used that and that's worked really effectively. So it's not just we haven't tried it out, we have done, and it's worked really well.
Brilliant, thank you.
Thanks,
Anna, do you want to come in? No. Rick, thank you. I think that, as I say, that's both helped us to understand the process that we're going through, but also the way in which we're reviewing and evaluating as we're going on, and then there's some questions around out of hours and training that we've also been able to deal with. So thank you. I suspect this is something we will come back to, but great to hear that it's going well at the moment. Thanks, Rick. Can I move now to...
Good point there, Pete.
Thank you. Can I move now to Nick? I mean, you can assume we've read this paper on the mental health resilience and recovery planning, but was there anything you wanted to pull out, Nick?
Thank you, Peter. If I just reinforce, Peter, the levels at which we're working and what the 3 or 4 key issues are, I think that would be helpful. So I will take the paper as read. We have had previous discussions as a board on the types of COVID-19 related mental health issues are likely to arise, both, well, arising currently, but also likely to arise moving forwards. You'll see in the paper a summary of those. I also would like just to refer the board to a really good paper just produced by the Centre for Mental Health, which is entitled COVID-19 and the Nation's Mental Health. And I think if you want a really good summary of the issues in addition to the paper, that describes it. And then in terms of how we're working on this, we're working at it really at 3 levels. So we're working it at a Southeast Coast level. And just one example of that is that one of our psychologists actually works in critical care directly with COVID-19 patients and also with staff working with those patients. So she's in a full PPE kit. And some of the learning from that is really being taken both regionally and now nationally. And we're supporting then a piece of work which is about developing proposals through the Acute Care Forum for increased psychological provision in critical care wards. So that's being supported nationally. It's an example of a piece of work that we're working collaboratively together at a Southeast level. At a system or ICS level, you've got the details there of the planning work that we're doing. Again, just want to reiterate, Anne, it's very much based on the principles that you outlined earlier on. If we're going to transform mental health services and we're going to respond appropriately to the psychological challenges of COVID-19, we have to do mental health in a different way. We have to involve the wider community in much greater partnership. We have to see a much broader range of providers delivering healthcare, and we need to really think clearly about the relationship between key factors like social isolation and mental health, and be very clear about our role and our role supporting those broader agendas. So that's what's happening at that level, and you can see the detail again in there. And then at a trust level, this is the piece of work that very much the SIM is leading on through OPS. It really is about 2 things. One is making sure that we are prepared for those likely surges in demand that you can see in the first part of the paper. But secondly, and as importantly, making sure that some of the really good things that have happened in consequence to COVID-19, I'll mention just 2, the mental health helpline and the creation of the urgent care hubs. I can't resist, I'm going to have to mention 3. And I move to digital online platforms. Just 3 examples of things that we really want to make sure we embed as part of that ongoing transformation and resilience work. I'm not going to say any more because later on we'll have a chance to get Mark's external feedback on some of those issues. So work's happening at all 3 levels, and I'm happy to take any questions.
Lovely, thanks, Nick. If there aren't 3, there's normally 1 missing, isn't there? So I have a couple of questions, but let me ask other people first if they've got questions or comments for Nick. Anna, please.
Just one. So I mean, thank you so much, Nick. And I think, building on what you kind of updated us on before, I thought this was really helpful, and I really kind of commend the work. I had a slight worry just on and it may be being a bit pedantic, but it's back to the point about language. In your table 1, Nick, where you talk about, sorry, it's at the top of page, so it's table 1, but the top of the next page, whatever that is. The predicted 8% increase in stress, 28% increase in anxiety, 16% increase in depression. So I was really intrigued by that. So I actually had a look at that study, and my sense was that it was saying, you know, this was a small group in China in the middle of the height of the pandemic. They had a 3-day snowballing sampling survey, and they found that, you know, 8% had moderate to severe stress levels, and 16% had moderate to severe depressive symptoms. So I'm just slightly worried about kind of going from that to saying this paper is predicting these percentages, simply because, you know, I think it's difficult to kind of go from a study in Wuhan at the height of the pandemic or the crisis there to, is this generalizable to Sussex? And I just felt it was slightly that people could read it that way. And I don't think that's what you meant, but that's certainly how it could be construed, that we're able to talk about, you know, percentage increases in whatever. Well, at the moment we probably can't, and we certainly can't for Sussex. So it was more about a common point, and the you know, how we, you know, in a sense, what you're then going on to say we're doing is absolutely, you know, to me on the right track. But that one and the other one, the 2015 study on patients with lung injury, I again wasn't quite sure how that exactly related to what we're talking about here. But
I think they're all good questions, Anna, and I do think we are absolutely acknowledging that in many areas we don't have the evidence that we would ideally like in order to really be able to predict what the impact of this is going to be. So we have to make do with what we've got. I do think the using the estimates that you know, our understanding of the impact of critical care on people suffering from pulmonary difficulties is a very good actual estimate of the likely impact of COVID. So I'm less worried about that one. I do absolutely accept the limitations of the China study. And I'm certainly more than happy to just tone down the sort of the predictions. It was meant to be drawn from the China study, not make specific predictions. So I can certainly do that. It's interesting that the other estimate, if you look at the 2008 recession, for the figures, that the estimate again there is that 500,000 people suffered increased levels of anxiety and depression as a consequence of 2008. So again, this is all data that's we're trying to build a picture around, but I absolutely do accept that, and I'm very happy in that paper in future just to make that clearer, that, you know, that is a specific China sample.
Thank you. Thanks. Any other Anne, please?
Yeah, just on the data and prediction of what's needed, I think the tables are so fantastic, a very accessible format, and it shows how, you know, we're really thinking so well. So that was fantastic, Nick. But if we look at sort of an old-fashioned, so do you remember the positive psychology and how you estimate communities' happiness? I think some of that, that data and those figures are very important for us. And what that data from all that time ago, whether you believed in the positive psychology approach or not, and happiness scales, what it showed us is that periods of uncertainty create the most angst and depression and worries and anxiety. And if we are to enter a phase of maybe lockdown, coming out of lockdown in regions, I think the government's response at the current time will, sadly, I believe, create an even bigger demand on our services. And that's not just in the physical sense, it's obviously in the sense of living with uncertainty for people who are not privileged. I don't want to talk about class, but people who aren't privileged their response to uncertainty is much more dramatic than people who are privileged, because of, you know, a lot of things. So looking at that element of kind of data and our response to it, the only thing that I would ask is, at a system level, the NHS will have to start signposting to very practical support, benefits, advice, housing support for people who've been abused, people in poverty, and so on and so forth. So it's the signposting away from our services to practical support that we absolutely, I think we must create.
Completely agree, Anne. And just 2 points to add to that. That is absolutely the heart of our adult community transformation work. And the second point, specifically and related to COVID-19, I think the point that you're making, which is really helpful for us to work with as well, is that addressing the emotional consequences of this illness is actually the responsibility of the whole system. We as a mental health trust can't tackle loneliness on our own, or uncertainty on our own, or all of these are really important factors that increase mental health problems. But actually, if we're going to tackle them, we need to tackle them as a system and as a society. And it comes back to that role of what role do we then have as a trust, as a leader in supporting that type of work and that type of conversation, without opening our doors to, I mean, we can't be the solution as a trust to loneliness because we haven't got the resources, but we can help work with a wider system to really think more clearly around loneliness and how we tackle it.
I quite like, if I may, to follow that up, Nick, because it links to my. So I had a comment, which is that on the final page, when you're talking about implementing local solutions and priority groups, I mean, it may be that I'm looking through a slightly distorted lens, but I'm picking up a lot about the numbers of people of LGBTQ+ who are potentially negatively impacted by lockdown. And given that they tend to be overrepresented in mental health services anyway, I wonder whether they ought to be, and given that we have significant clusters of population across our patch, whether they should be a priority group in the implementing local solutions. And then my question was, it does a bit on stage 2 and what our next step is and when a next step is. But there is something for me about the economic and social impact of this, and what can we as a trust do to reduce the economic and social impact. And I suppose I'm thinking of the work we're doing with colleges, the work we're doing with employment services, but also can we address some of our workforce challenges by thinking creatively, but then also improving the economic circumstances of local people who may have become unemployed as a result of this time. So I suppose it's where and when we might start to include that as something we can do that would improve people's mental health. That was meant to
so in terms. Sorry. Yeah. Sorry, did someone come in? Shall I respond to both of those points, Peter? Your first point, absolutely agree. And what we're really asking is for, at a place and a neighbourhood level, for teams to come together and specifically identify the at-risk community groups at their level, so that we target interventions really at a neighbourhood and place-based, with a neighbourhood and place-based focus. And Sim is very much working with our local transformation groups, which is a sort of a more than us, it's sort of a wider group to do that work. And I would agree with the LGBT statement. The second issue, in terms of the type of areas you've described there, I think they're all a really important part of our preventative agenda and our preventative element of our new organisational strategy. So it is about, I think, how we really begin to, as we move out of the immediate COVID crisis, how do we then begin to move forward into restoration and recovery that includes the preventative agenda and the type of things that you've described within that, Peter. And I can mention very small, I can mention projects that are already occurring. We're currently liaising with Citizens Advice Bureau to support a joint bid with them for developing psychological advice and signposting in their centres. And there are other things like that which I think need to be part of part of that process. So I think, as far as the board is concerned, I do think probably refocusing our attention on the preventative agenda as we move forwards is going to help to address those sort of questions.
Okay, thank you. Sam, did you want to come in?
Yeah, if I may briefly, Chair, I think to add to that, I suppose just give the board the assurance that we are engaged in all of those conversations with our partners. I think it's really important that the whole health and care system takes on responsibility for this, and that is what it's doing through the integrated care system and planning approach. It will not be our sole responsibility or priority to do this, but we absolutely need to focus on the needs of our patients, population, and bring our expertise into this conversations, which we are doing. I suppose I just want to, and I sort of do this at regular points, just to caution that whilst we are rethinking, the impact that this has on our strategy, our strategic risks, and our prioritisation, we are still absolutely in the midst of a level 4 major incident. We are 80% of what we're doing is absolutely focused on the basics still around safe and responsive care. And we are, whilst we're making really great strides, I think, on the planning through the next phase, that will happen over the weeks ahead. And I think the opportunity to engage our governors in that, alongside all the work that's underway through people participation already, together groups, will be really, really invaluable.
Yeah, I was careful to say that it doesn't depend on the interpretation of next steps.
Yeah, Pete.
Yeah.
Sorry, Pete.
I'm just a little bit unclear as to how we handle this or what our approach is. I think it's absolutely laudable that we are partnering, collaborating with not-for-profit organisations. But wonder what we do and how we work with them, where they are clearly the best people to provide a service, but they don't have the financial resources in order to deliver it. Is it our position as a large provider of mental health services that there is some way of actually helping them with their funding, or is that only done through, Nick mentioned, putting in CAB and applying joint bid for funds to resource a project, but can we directly do? And you say yes. Sorry.
So shall I answer the question, Peter, and then we'll pick it up from Anne?
Yeah.
Okay.
Nick.
So the answer to the question, Joe, is that the third sector are going to have to be really important partners in mental health delivery moving forwards. You're absolutely right that one of the key problems for the third sector is the sustainability and security of their funding, and we'd hope to really help that in two ways. One is that a significant proportion of the additional investment in mental health will be available to go into the third sector. The 19 million for 2021 is not just SPFT money. It will need to be spent across that broader system. The second thing that we're doing is by developing integrated pathways of care, and we do this for veterans, if we really work closely with third sector partners in a way that makes them integral to the delivery of a whole pathway, it really strengthens their case in them being able to secure ongoing and permanent funding with the sources of funding that they can draw on. So we hope to help it in both ways. Both there'll be NHS money that they can draw on and use, but by working in a collaborative way, it really strengthens their case. And we would want to make a really clear case for third sectors being able to operate in a more sustainable and long-term, in a more long-term planning way.
Okay,
Thank
Joe.
you.
Thank you.
That's fine. Thank you.
Thank you, Peter. It's a comment which I was going to possibly save till the end, but it's been prompted by what Sam and Nick have said in their respective roles here. I think Sam, about we're still dealing with a level 4 incident, or whatever we're calling it, and whatever the label is, and we shouldn't forget that as a priority. And Nick giving, for me, an exciting and tantalising glimpse of how we might do things differently in the future, when he mentioned in passing, I think, the citizens' advice link up. Because for me, those are the two issues that I was am looking for, actually, throughout all the papers we read. How do we continue to respond to what's in front of us, which is the most important? And I think that's been brilliant so far, and let's keep going. That's great. And how do we start doing things differently? And if you'll indulge me for 1 second, the restaurants on the seafront in Hove that are starting to reopen are doing takeaways only, in a quite different way of doing business, because there's a different requirement. And I just get a sense of that from Nick. Forgive me, Peter, it's not for now, and it may have been for the private meeting, but I like what I'm hearing in terms of priorities and deeper thought and innovative thought for further down the line. Forgive me for putting that in now, but I just wanted to say it now.
Okay, Martin, thank you. I think that's a helpful way of transitioning us. So I think that we acknowledge that we are still in the midst of a level 4 incident. I think it's good that we're starting to think about the planning, but we must be careful not to think that that's all going to happen tomorrow. But I think it is good to see the collaboration and the collaborative work that we're doing across the system. I also think that, as we've discussed, that there are some opportunities for us to use this situation as a way of actually tackling some of the long-standing workforce issues that we've had. That we need to be clear about what we can do as an organisation and what we want to contribute to as a system. I'm going to move us on. I'm doing terribly on time, but I hope people will accept that actually we needed to flex that item to cover the ground, and hopefully we now can make it up. Sam, before we move on, I mean, you rightly said that, you know, to what extent the breakthrough objectives change, we can review, but certainly what we prioritize that we're doing within those breakthrough objectives may need to change, and the conversation we just had sort of reinforces that, doesn't it? But I suppose it would be interesting just to think about, what do you think has your view of what some of the key risks are for us changed at all?
Yes, thank you, Chair. I think one of the risks inevitably will be around capacity, around leadership capacity, and, you know, balancing the ongoing demands that the pandemic is causing on services, particularly around recovery and restoration, with and alongside the transformation, but also within that there comes opportunity. So one of our most significant risks has always been around our workforce, and being able to retain and recruit the workforce, when actually, given the way the environment is changing and is forecast to change over the weeks and months ahead, actually that may create some real opportunities for us around availability of a new workforce for right service, actually. So I think there are risks and opportunities, Chair. I think again, in terms of, and this will link into our conversation around our risk appetite, I think it's really positive that, you know, we should continue to take a mature approach to seeking out innovation, because again, and it is challenging because we're learning every day, and Nick touched on the Learning from COVID project that we are doing at the moment, which we'll bring through board this month, but that will inform, I'm sure, some opportunities for us around further work around digital, our operating model for our workforce. But I think the issue around capacity is similar to the one previous. It's just that the demands that we're facing are slightly different. I've got no doubt that you know, increase in terms of what evidence Nick's drawn on in his paper, the evidence the Centre for Mental Health published last week, the increased prevalence essentially of mental health difficulties in our population, don't get the preventative piece right with our partners, could become an extremely pressing risk over the weeks and months ahead.
Thanks, Sam. That's really helpful. So I'm going to move us on, but Dan, did you just want to say something about, I mean, there's been several references to the way we're communicating with our patients, with our staff, and with local people. Did you just want to pick up on that before I finally move us on?
Thank you, Chair. Yes, I will be very brief. I just wanted to touch on 4 aspects of our ongoing communications approach, which I think do relate to the conversation we've just had. Firstly, in terms of the next phase, and I'm a bit of a stuck record on this one, but it's really important we maintain our message discipline with staff. And what I mean by that is remaining focused on the key information and guidance that our staff need. Secondly, as Anne mentioned earlier, really important we identify opportunities for dialogue, engagement and listening. One specific example is the tweet chat we're holding tomorrow evening for families and carers, but we also need to think about staff in terms of that ongoing conversation. Thirdly, there's the broader issue of our organisational narrative and being able to describe with clarity and purpose what the next phase looks like for us, particularly in relation to issues like planning for the anticipated surge in demand, workplace safety, infection prevention and control. And then fourthly and finally, there's the ongoing work we're doing to provide advice and information to the public on mental health, well-being and resilience. So I just wanted to highlight those 4 key aspects of our comms approach.
That's really helpful, thank you. And I know from the email traffic there's been that people are very appreciative of the quality of the briefings that have been going out, the quality of the statements that you're sharing with us. So thank you and the team for that. I'm going to move us on. As I say, I apologise that we are running significantly over time at the moment, but hopefully people accept that this is still one of the key issues and one of the key areas that we need to focus our time on. I think we've received some assurance around the way we're responding to the level 4 incident. We had a good conversation about the extent to which we're now starting to think about how we might respond to the needs of our population as they change through the next phase. I think we're also aware of the need to focus on staff well-being and the issues that specifically come up around our BAME staff and the issues there. And I just wanted to seek the board approval for the statement that the Chief Executive wants to make to our BAME staff. Can I just assume that that is approved? Yeah, thank you. Yeah. And I think also then some of the key strategic risks that we need to address as we're going forward. So thank you all very much for your patience there, but also can I particularly thank the contributors for the quality of the papers that have been produced to help us understand and manage the level 4 incident. So can I now move us on, please? And can I move to the annual plan quarter, where am I going? No, I'm not. I'm going to the Quality Committee report. I apologise.
Okay, so thank you, Peter. I think I wasn't actually chairing that meeting, but I think the summary crystallises what happened there, and I'm not going to add any further to that. I don't know whether Anna or Kosha want to say anything more, but I think that the front sheet, I think, summarises it very well.
Okay, so did you want to add anything?
Just two points to highlight then, Peter. The first is to really flag the amount of improvement work that we were taken through as it relates to Langley Green and Millview. The teams were able to set out for us the impact of their work, both for staff working in the services and also our patients, which was fantastic. So to bring that to the attention of the board, because we know that's been quite a big piece of work for both of those teams. The other aspect to highlight is the work that the committee has begun on our QIAs for 2021. So reviewing those as always to make sure that they are delivering good clinical effectiveness and maintaining good patient safety and experience. So those were the two areas just to flag, but no escalated risk, and overall a good meeting.
Okay, thank you very much. I mean, normally we would spend a lot more time on the quality committee report, but I kind of feel that actually the key risks to quality are the ones we've been talking about through our discussion of COVID-19.
Absolutely.
I'm conscious, Kozia, that one of the things as chief nurse, you've been I mean, I know everyone agrees with you, but one of the things that you've been the mouthpiece for is keeping an eye on the basics. Are you fairly confident at the moment we're managing as best we can to keep an eye on the basics?
I am, Peter. I think through the work and the collective effort of the executive team and our leaders across the organisation, we've been able to keep a number of things in place and do that in a way that hasn't added additional burden. And I think the support of the Clinical Professional Advisory Committee and commissioning that very early on, and the ethical framework has only enhanced what we're doing. So I'm quite confident at the moment that we've got the basics and we're keeping a good eye on those.
Okay, thank you very much indeed. So thank you for the Quality Committee report. Can I now move to the Integrated Performance report, please? As usual, you can assume that we've read it.
Yep. Thank you, Chair. So I'm just going to assume that everybody's read the report and just pull out 3 key points that I wanted to make, and hopefully that builds on that last comment about keeping eye on the basics. So first of all, to just let people know that the more detailed PDF IPR paper at the back is month 12 data because of the sequencing of board, but the cover paper itself has been updated to reflect some of the key issues that we wanted to take note of and comment on. So the first thing I wanted to mention was around patient flow and out of area placements. As the report says, since April the 8th, we haven't had any out of area placements. We have over the last week made 1 ECR, and that is for somebody requiring a psychiatric intensive care unit bed in a female only PICU environment. But otherwise, we've been doing very well in that regard. And I think important to mention that that has not just been because there's been a reduction in demand. Actually, when we've looked at the data, that indicates we've had the same patterns of admissions as we did for the same period last year. But what has really made the difference, as the report describes, is our reduction in the length of stay of some of our patients. So the reduction in over 60 days length of stay and over 30 days length of stay. And that is what is predominantly had the impact. So going forward, continuing to really work with the wider system on ensuring that people have not got a delayed transfer of care, and those that are medically fit for discharge are moving on very quickly, and we've got good engagement from the system and some useful solutions in place that are really helping. I think it is fair to say this is something that we will obviously keep our eye on over coming weeks and months, because our the referral numbers are increasing, and so really important that we do as I've just said, but also we continue making sure that our crisis resolution and home treatment teams are able to support people where that is appropriate to remain out of hospital and safely to be supported at home in the community, and that of course is important from a COVID perspective as well. The second point I wanted to make related to the completion of care plans and risk assessments. As the board is aware, this has been an area of particular focus over previous months. And what the report indicates is that performance has improved significantly in the last 4 weeks. We've got a really very focused approach around this. Each team is looking at the detail in granular detail and has team reports that they receive each week so that they can really pinpoint and identify some of our lead practitioners where this has been more of a challenge, so that we can actually look at every single case and ensure that our patients have got risk assessments and care plans. And that, of course, is particularly important at these times where maybe some of them are not being seen face to face in the way that they would. So we've had to work quite hard to pick up on some of the consequences of COVID to do that. But as I say, over the last 4 weeks, the number of outstanding care plans has reduced by 1,800 and the number of outstanding risk assessments has reduced by 900. Each care delivery service has got an action plan in place and a detailed trajectory. And important to mention where, and the report talks about some unallocated cases that are not allocated to a lead practitioner, important to be aware they are allocated to the team. So some of the data cleansing work has helped to resolve some of that, but also those particular cases are being absolutely risk assessed and care planned in terms of as a priority as part of that triaging process. And we are doing some work to introduce an interim care plan for patients where a more detailed assessment is required. And so whilst that is being completed and that care plan being built on, we want to introduce this interim care plan, and that's gone through a variety of different places to support that going forward. And then finally, I wanted to mention about the use of agency staff, and obviously Sally will reference this in her papers, and it was discussed at F&I the other week. But just to say, at the moment, obviously we're aware that agency expenditure is above average levels, and this is something that we really want to focus on over the coming weeks and months, whilst at the same time not compromising safe staffing levels. So I've been working very closely with Sally and her team, and with Gavin and his team. Rebecca Hills, who is the new Assistant Chief Operating Officer, is also helping to carry out a programme of work where we really do focus on this. And in particular, we are looking at the rota management system, ensuring the teams are completing that well in advance, as well as looking at the good use of bank, the recruitment to bank as substantive staff, and just making sure that our whole workforce plan supports that, because what we're looking to do is to really have this very clear trajectory to certainly reduce the use of non-professionally qualified agency staff. In the interest of time, Chair, I'm going to pause there for any questions either related to that or anything else that's in the paper.
Okay, I have one question, but let me ask other people if they have questions first. And
just to mention that the audit yesterday, we talked about the overtime payments and that issue of overtime being worked, both in terms of quality of service that people can provide, but it strikes me that that should be taken as part of the round discussion with agency staff.
Yeah, so is that a comment or a question now?
I don't know, it's just to make sure you're aware of it.
Yeah,
I'm sure Sally will let you know.
Thank you, Anna.
Sim, I just think it's fantastic that you've got the out of area down to 0. So really incredible under the circumstances. My question was about the waiting times, and it perhaps relates to what we're going to talk about later on, but and it's a kind of thread, I suppose, that runs through lots of things. The issue of how much we can start to think about remote consultations for certain, I mean, I'm very well aware this is only a small group, subgroup, but that young people who, there's sort of some evidence coming through that young people do, respond well to having options for how they're consulted with, phone, text, apps, online, as well as face to face. And I just wonder whether, I just wonder to what extent that's in the kind of the kind of menu of solutions to the waiting time issue. I'm not really saying that this can be solved without, you have to have face to face, but I'm just wondering how much that's in the mix of solution.
Yeah, absolutely, Anna. I think key, and actually in terms of the use of sort of digital means of contact, Attend Anywhere has been used very successfully by lots of people, but in particular of our children and young people services. And what the learning for us is from gathering data back from people using our services and their families and carers, whether we're talking about children, young people or adults, is that many people are really accepting that well, and think that it's a great way to contact with them and to interface with them. There's some evidence, which hopefully I can bring back to a future board, that that's reducing some of our patients who might not be attending appointments, so it's reducing that. But building on the work around responding to the second phase, our community transformation piece, we really want to introduce and use these sorts of mechanisms, probably more telephone contact, certainly more digital mechanisms as part of it. And I think you're right, that really helps us to be most effective and most efficient, and is responding to what people are asking us for. So yeah, absolutely, very good point.
Thank you. Any other comments for Sim? Rick?
Yeah, thanks, Chair. So really picking up on Sim's point about options for young people, just to flag that this month we've launched, in collaboration with some partners at the ARC and also YMCA, a young people's digital platform, which I know Beth has been involved in as well. And I'm happy to circulate a link for that. There was a soft launch a couple of weeks ago, and there's the proper launch 1st of June. And it's a really, really good, I think, way of engaging young people in looking at ways of improving mental health. So that's the well-being agenda, but also accessing help when they need to. So the pathways are consistent with our own children and young people services. But that's another, I think, really innovative piece of work that's happened during this COVID period. And what we're going to look at next is increasing the age limit from 18 to 25, and then even opening up in the future, I think, for all ages as well.
Okay, thank you. Sim, I mean, it's fantastic, isn't it, that we've got out of area placements down to 0, we've got delayed transfers of care under control, we've got the I've lost a simple phrase, but you know, it's good that we've got that under control at the moment. What's the key risk looking forward for you? What is the thing that worries you about the next phase?
In terms of well, a couple of things, I suppose. I think in terms of the out of area placement, we are seeing a significant increase in numbers. I think managing, even with the cohorting that we will be able to do, we've got plans in place across all of our wards to cohort patients who have COVID symptoms. I think that potentially will reduce some of our capacity. So I think we've got to continue to be really smart at focusing on how we continue with the throughput and making sure that people are only in hospital for as long as they need to be. I think the whole issues around workforce continue to be key, as Sam has already flagged up, and that will be an issue for us in terms of responding to an increase in referrals into our community and being able to do the right thing by people in a very timely way. So probably those two things are a risk, but I think there's huge commitment from our staff as always, and people are very committed to using innovative ways to solve some of these problems. So okay. I live with optimism as well as some degree of trepidation.
Okay, Sim, thank you very much. I think, as you say, that was that's the report for month 12, and obviously next time, I think when we look at the report, we'll look at it in a bit more detail, but I think that's helpful for today. And it's good to hear both the innovations that are taking place and the way in which we're evaluating those innovations in terms of what we can continue and embed. But we note the issues that you flagged in terms of the potential increase in demand and the availability of a workforce to deal with cohorting and an increase in demand at the same time. If I could now move us on, please, to the Finance and Investment Committee. Martin, can I come to you first, please?
Yes, you can, and the paper is really by way of assurance at two levels, I think: general scrutiny and the read across tool that Sim has just been speaking about. To me, it's always reassuring that what we get from performance and ops is reflected in F&I. I wouldn't want it any different way. I am now about to deliver a hospital pass to Sally. My only consolation is she knows it's coming because we communicated yesterday. Because since that finance committee, of course, we've had year end, which I think is good news, and we've also had a further F&I last Friday, which I think we should usefully spend more time on than the rather historic paper that my name is attached to. So, Chair, if you're happy, I will pass it on to Sally.
That sounds eminently sensible. Thank you, Martin. Sally.
Yeah, Martin and Chair, thank you. So really as a segue between the Finance Investment Committee report and the month one report, it's important that we know publicly our year-end position. We took this through the private board in April, but just for the record, we delivered a surplus just under 1.7 million, which was a remarkable achievement given how the financial challenges from last year had impacted us. We delivered a 300,000 operating surplus, and we were lucky to receive additional funding of just short of 1.4 million for mental health from the centre. Clearly, we'll be taking the accounts through the board today and presenting them formally at the AGM later in the year. So if I move on to the month one report, as much of the conversation this morning, the month one report is set within the context of COVID and the financial regime, which really is quite unprecedented in that we've been issued funding to break even from April to July. We understand this has now been extended until October, and we believe it will probably be extended for the rest of the financial year. So, as I say, unprecedented position we're in. I think there's a number of things to really pick up from that, all related to the discussions we've had. Clearly, we're incurring COVID costs, not to the extent of the acute trust, but in April we incurred 800,000, which was significantly higher than the 390 in March. That is being topped up from central funding, and then to break even, we requested a top up of 190,000. The opportunity this brings for the trust, though, is to really make sure that we get ourselves on a sound financial footing going forward. I anticipate that given the money that's been put into the NHS and the financial support given to the wider population with furloughing and all the things we've talked around this morning around the economy and how that will look, I anticipate that 21-22 will be a challenging year for us. So we must use this opportunity best we can to really get ourselves on a sounder footing. If you look in Appendix 1, you'll see that there's quite a significant variation between the performance of our care delivery and support services, although to note that the support service cost does include the 800,000 COVID costs. So the four areas of work that we will be focusing on this year is out of area placements, as Simon has touched on, the agency and workforce, and I think on that, as again Simon has spoken about and set out in the report, there's a number of areas where we need to make sure we take grip, but take an opportunity of workforce opportunities in the system. And through our finance meeting, we want to do some work, particularly in Crawley, to make contact with the HR departments of some of the airline industries where we know there's been a high level of redundancies, to see whether there's opportunities to look for new recruits in those areas. And then really exciting work we're doing with the Brighton Metropolitan College about training for access courses to bring more people into mental health. Nick particularly talked about the service transformation and the just short of 20 million that's coming into Sussex. It would be wrong of us not to make sure that we don't embrace that and spend that money this year. And there's a clear steer from the National Finance Director that the Mental Health Investment Standard needs to be spent this year, not only to give that opportunity to be on par with the acute sector in terms of investment, but also the need for the transformation. So we must take that forward. And picking up Anne's point about the third sector, not all of that money will be coming to Sussex Partnership, but we'll make sure that where possible we can develop those pathways and to make sure money goes to the third sector. And then finally, in terms of support services, they overspent last year, and working with Sam and Paula Wilson, my deputy, we will be doing a piece of work to make sure that support services are aligned and can really enable the work that I've discussed above. So before I open up for questions, there's just a couple of other things to raise. In terms of the capital forecast for this year, we've been asked to reforecast our capital programme, which we think will reduce by about £1 million to 14.7, but clearly that's dependent on the construction industry and manufacturing getting back up to speed. We're really embracing the opportunity around the business case development for the East Sussex redesign, and I've asked the chair if we can do a particular piece of work in June around our estates programme and get the rest of the board up to speed on the case for change in East Sussex. And then through the F&I committee, I think it's just important to acknowledge the level of cash. I think that the trust was holding at the end of April, 73.9 million. But I think just to really flag, even though I think it will attract system attention because it's particularly high, we were paid twice in April to maintain cash flow, particularly to support small businesses. So our payment terms have been reduced from 30 to 7 days, and we have, we've got uses for that cash around. Obviously, some of it was prepaid support, and other will be to support our capital programme. So I think I've covered everything, Martin, that we picked up on Friday, but happy if you want to add anything or open up to questions.
Thanks, Sally. So we need to be absolutely clear to our colleagues across the system that the cash position is something we're aware of, that it's inflated by the double payment, and we have absolutely clear plans for how we intend to spend that money.
That's right, yeah. Thank you.
In the coming months.
Thanks. Peter, can I just make a quick comment?
Can I open it out? Martin, did you want to come back?
No, I'm happy that I think Nick wants to come. I know
yes,
that.
Thank you.
Thank you.
Nick.
Thank you, Chair, and thank you, Peter. Just two things very quickly, won't take a minute. A massive thank you and recognition of the brilliant work of Sally and her team. What a great result. So an enormous thank you. It makes our job in F&I that much easier, having that brilliant team behind us. It felt for me a certain sense of deja vu, however. This is the second year I've been involved in the year-end process, and it felt like Sally and the team, snatched victory from the jaws of defeat again, and that sense of tracking behind all year only to get things resolved at the end kind of feels sort of unnecessarily stressful and unhelpful, actually. And I just want to make sure that the offer from myself and from the Neds to do anything we can help to support Sally or anyone else in the trust to fight the corner really around trying to avoid that in future years. So I just wanted to make that really clear. Second thing as well is that I suppose the I&E position is brilliant, absolutely wonderful, but that cash position, we've all said it, really, really important. We now need to make use of that as in a way that allows us to think about our capital, think about our buildings and the transformation that's required in some of them. So again, doesn't need any response, just a big thank you to Sally and the team.
Thanks, Nick. Sally, we've talked pre-COVID, we talked about the need to have a conversation about estate, which is both in terms of potential new development, but also the environments in which we're putting staff and patients. I mean, clearly, with new ways of working being accelerated through COVID, our attitude to estate may change, but it doesn't remove the point, does it? That we have some suboptimal environments in which people are working and trying to deliver care, and we have some significant gaps in provision. So is it timely? I'm very conscious of Sam's point about we're still in the middle of a level 4 sort of situation, but at what point should we revisit the conversation about our strategic estates planning and the way we're going to address that? Rather long-winded question, apologies.
Yeah, thank you, Chair. I think there's sort of 3 bits to that. We know that over the next 5 years, we've got capital pressures are about 100 million, and a significant part of that is East Sussex. That will be a substantial piece of work with a build of about 70 million. We're envisaging a development the size of Millview to host our inpatient units in Sussex and our older people and dementia units, and that might be 1 or 2 units. It hasn't been decided, but it's that type of scale of development. And we know that that's something we won't be able to afford outright. So we're starting that work now. So I would like to bring something back. F&I committee had the opportunity to look at that and the case for change last week, but I would like to bring that discussion to the board sooner rather than later. So I think June would be quite timely for that. We know to support the other parts of our capital investment that we need to decide upon asset sales. Now might not be the time to sell them, but we can still have that strategic conversation. And I think that, again, we're ready to have that conversation. And then the third part, as you alluded, is a longer piece of work. I'm leading a piece of work on a safer workplace, and through the COVID work, I think there will be some buildings that are completely not fit for purpose because of the social distancing, and that's a piece of work we're working through a task and finish group, which will be a longer piece. I think will shape our whole estate going forward.
Okay, thanks, Sally.
Thank you.
So we'll schedule a conversation at June board strategy session on estates, but we acknowledge that that will be the first part of an ongoing conversation. Yeah. Okay, Martin,
yes,
please, and then Sam.
Thanks, Peter. And I was hoping I knew that Sally would mention East Sussex. The beauty of that for me is that it's a real project to get teeth into, but it comes at a time when we are looking at new ways of working. And therefore, I don't see it as a distraction or something to do anything other than plough through, but in a new context, if that makes sense. So it's hard-nosed business, which is good, and as Nick rightly says, every confidence in Sally and her team that therefore we'll be okay. But as was discussed at F&I, and as Sally has just alluded to, there's a real sense that it's not just a new project like Millview was historically. It will be a project post, fingers crossed, post-coronavirus and in that environment. So I see it as something both practical and aspirational, as Sally has outlined.
Okay, thank you. Sam.
Thank you, Chair. I just wanted to follow up and echo the comments made around thanking the finance team. We are incredibly lucky. Just on your reflection, Nick, in terms of the deja vu experience, I've worked in the health service for over 20 years now, and I don't think that experience will probably change as the years go ahead. But I do think one of the things that we can focus on, and particularly over the forthcoming months, is maintaining our rigor around the basics on finance in the same way we are doing on quality, making sure that our efficiency programs are robust, you've got clear actions and are being tracked and delivered in a timely way. I think there is not an acceptance, and it's certainly not an excuse, but the health service is a complex system, and perhaps one of the things we can do is an earlier conversation around some of the variables that we're dealing with and some of the dependencies. It definitely was very close at the year end, and I think we really felt the benefits of the working that we've been doing across the system with our partners and our commissioners' support, particularly around our spend on out of area placements last minute. It's very much a collective and team effort right across the board.
Thanks, Sam. Sally, thank you very much for the clarity on what the drivers of the run rate are. Thank you for bringing our attention to the reasons behind the cash position and also the need to really now move forward with a number of conversations around our approach to estates. This is probably the first time formally, we have said it before, the first time formally, that we just want to thank you and the whole team, both your team within the finance department, but also, of course, it's a collective effort with the whole of the executive team as well. But I think it is appropriate for me to thank you and your team for the work you've done to land us on a postage stamp on the 31st of March. So thank you very much. And I know there was some negotiating that had to be done towards year end, and thank you for applying your skill and expertise and knowledge to that process. Thank you.
Yeah.
I'm going to move us on. Again, my apologies that we. It's nothing like having 2 new board members and failing to keep to time, is there? So you can ask people whether this is normal or not. I hope not.
No, they had a good example yesterday of staying to time, so it's fine.
Thank you. So we don't need to discuss the audit committee report then?
We don't.
No, do we? Is there anything you want to raise on the audit committee report?
Thank you, Chair. I have nothing that I wish to raise in relation to the report. Sally, I don't know if there's anything you particularly want to raise, but this, other than the fact that this was chaired by Louis Doyle, and it was Louis's last audit committee meeting, and in his usual way, he took us very professionally through the agenda and the key points, and also made sure that we were very clear on what we needed to focus on going forwards. Sally?
Great.
No, nothing to add, Joe. Thank you.
Okay, thank you very much indeed. So, so my apologies, Lynn. Thank you for your patience. You're in the bottom left-hand corner of my screen. I was about to say thank you for your patience down there. You may be in somewhere else on someone else's screen. So thank you for your patience. We'll get to you very shortly. My apologies. So if we could look at the board assurance framework, and what I want to do is I just want to lead the board to start with towards what I think we need to do here. So I think it's important to remember that the board assurance framework is a prospective document. Board assurance framework tells us what we think the key risks are coming towards us, so that when we are looking forward as a board, we can try and assure ourselves that we have the mitigations in place to deal with the anticipated strategic risks. I think that Sam has already alluded to the fact that although we probably may not want to change, certainly won't want to change the 3 Ps, and we probably don't need to change the breakthrough objectives, we do need to accept that actually we are in the middle of a level 4 incident, and we need to accept that therefore certain things will get reprioritized, certain things will get accelerated, and some things may need to get reframed and redefined. And I think it's really useful in terms of what we've got in Appendix 2 to see the team's first thoughts on how risk appetite may change. And what I would like board members to do is to take a step back and just think about actually what are the things that we might actually have more appetite for risk around as a result of the desire to really capture some of the innovation and some of the acceleration, but also because we need to be realistic about our response. And I think that's something we need to do. In terms of the risks that we've been talking about through the meeting, and it won't be comprehensive, and I'm certainly not trying to craft them by committee, it seems to me that there's something about our needs to work with our partners to address resilience and recovery in the community if we're not going to see even further increased demand. We need to recognize our leadership capacity across the organization and the ongoing demand that the level 4 incident will create on leadership capacity, as well as the need to then continue to innovate and the need to continue to accelerate. I think there's something about also seeing an increased demand in mental health services if we don't address some of the economic and social impacts of COVID-19. And I think the one that we've talked about through the meeting is, can we create new opportunities, new roles? And I know there's been some discussion about new healthcare assistant roles that would be attractive to people and actually would draw people into our workforce with a clear career path that could be followed. There's something about actually making sure that we do learn from COVID and we implement the positive change, and that we would be disappointed if in a year's time we hadn't done that. There's the need to assess trust and mistrust across the system. And then there continues to be the pressure in terms of on our finances, in terms of controlling agency and controlling out of area placements. So just through this meeting, that seems to me some of the risks to both quality and finance that we've identified. And I think that some of those resonate with what we've got in the existing list of risks in the Board Assurance Framework, and some of those change, because I think actually the nature of the risk changes, as well as our risk appetite. So in a moment, I'll get people to comment, but what I'm proposing is that we take this through to our board strategy session in June, and that actually we ask the executive team to continue to work further on what they think the key risks are, to work further on the risk appetite, and we'll come together and look at what has COVID-19 meant for the breakthrough objectives. What do we think our priorities are now? They may be the same, they may change. And then what are the key risks to delivering those objectives, and what's our appetite for risk? And that's important to make a distinction between our risk tolerance, and we're very good around risk tolerance in terms of quality and safety, but also our risk appetite in terms of things like quality, safety and finance. So I think what I'm proposing is that we note this for today, and actually we give ourselves a bit of space to talk about this more fully in June. But I'm happy to take any alternative suggestions or comments that people may have.
Peter?
Yes, Martin.
Not an alternative, very much a supportive, hope complementary, because I think some of this is how to facilitate a meaningful seminar discussion next time, as you outlined. And the only two bits, one's been mentioned already and one is always in the room, that I would have just added would be East Sussex project and the clinical strategy, which has served us so well so far. For me, the equation, and it's only just one way of illustrating it, is clinical strategy plus coronavirus plus the future way of working equals what sort of thing. That's meant to be complementary to what you've just said.
That's helpful. That's helpful. Thank you. We'll certainly take that on board. Okay, so I'm taking it that people are happy with that approach. I'd like to thank the team for pulling together the initial thoughts around the risk appetite. So we note the Board Assurance Framework as at 31st March 2020. We note the appendices in terms of risk appetite, and we agree to reconvene in a fuller discussion on the 25th of June to complete this process, which can then be signed off at our board meeting in July. So thank you all very much. Lynn. Hello.
Hello, thank you very much, Chairman. So this report is the annual Speaking Up report, which is the second time that this has come to the board. Last year was our first attempt. I think that it was pleasing to see that we have had more people speaking up in the year that's just finished, the year that ended March 20, 53 this year. So we've seen a steady incremental increase year on year since The Guardian has been in post. And you'll be familiar with the different ways that we try to engage our staff to speak up, either to their line manager, to me, through their networks. And this report enables the board to see not just the speaking up that has happened to The Guardian, but also where it has either gone through to HR, or where someone's raised a grievance, or indeed where they've decided to speak up to the Chief Executive's office about something. And the report highlights a few differences in that. So generally, I think we are sort of in the middle of our sector when we look at the activity that we had for speaking up. And I think that's a good place to be. But I'm always keen that we have, as many speaking up as we possibly can. And so there's been a drive while we've been in the COVID lockdown, just to try and keep reminding people about speaking up should they need to. This year, we haven't got the national data to be able to compare ourselves against. Currently, The Guardians have not had a pressure put on them to put their Q4 data into the system. Some of the guardians who are clinical have obviously moved across and tried to do a clinical role at the time being. So we'll get that later on in the year and be able to compare how our Speaking Up has compared to the rest of our sector. Plans for the coming year to work just to do the review of the board toolkit that we've had before, and just make sure our strategic plan for Speaking Up is going to be up to date. And so we'll get that done. And we're going to be keeping an eye on the detriment issue that the board's been cited on for the last 6 months or so. I've been doing a little bit of work with Sam to look at that, and there is an inconsistency across the guardians, I feel, around detriment, but nonetheless we're keeping a close eye on it, and I'll be taking some work forward on that. Matt Green from Human Resources produced the information around both grievances and about dignity at work, and I think it's fairly self-explanatory there. I think numbers have been broadly consistent as regards grievances that have been brought to HR, and I think same with dignity at work. There's been slight variations, but roughly in the same ballpark figure for that. Counter fraud, again, you've got quite in-depth detail there from Matthew, who works with the trust to bring that information to you, and you've got some figures there. Consistent Speaking Up, but an improvement. We saw an improvement last year, and that improvement has been attained. So I think perhaps we are getting into a good Speaking Up culture generally, whatever the situation a member of staff's experiencing. So I think going forward, I think the board can be assured that we've got good uptake from the organisation as a whole, and I'm seeking different ways during this lockdown just to try and remind people that they can speak up in different ways while I'm not able to get out and do as many visits as I would normally be at this time of year. So just any questions if people have got them.
Okay. Lovely, Lynn, thank you. So thank you for raising the points around detriment. I think that was something the board has raised before and we wanted to cover today. I think I just want, as chair, to echo the fact that I think that actually more people speaking out is a good thing for an organisation. So I think we welcome that, and I know that Sam does as well. So thank you for your report. Does anyone have any questions for Lynn? I think it's very clear and self-explanatory.
Peter, it's Gavin. Can I just quickly make a couple of comments?
Yep.
Yeah, thank you. It's just two really. I think first is I think it's really important that we keep an eye on the number of anonymous cases that come forward, because certainly experiences, they tend to be harder to investigate and come to an appropriate conclusion. I think there's something in there about psychological safety, and it's a good litmus test as to whether we're creating the right level of psychological safety in the organisation, that staff feel that they can name themselves when they speak up. I think the other issue I just wanted to flag was the wider casework, grievances, etc. mentioned in there, but the development of the relationship that the trust has now got with staff side colleagues. I hope I don't read the day I say this, but I think that we've done a lot of work in developing more positive working relationships with staff side, and that's definitely had a positive impact, I think, in the way that we're handling some of the employee relations cases that we've got.
Okay, thank you very much.
And so, Peter, could I come in, Peter, please? Yeah, just as a reminder, I think as part of my role as Senior Independent Director, I have quarterly meetings with Lynn, which are always helpful and informative, and just want to give colleagues assurance really on the four areas that I tend to look at. One of which, where do we fit when comparing? And I take Lynn's point that comparing ourselves with others at the moment is a little bit trickier, but are we an outlier? is one area, and we don't seem to be. My next area is what, and I know Sam is on the call obviously, but what is the CEO engagement and involvement? And it is thorough and comprehensive. Allowing for the confidentiality issues, is this embedded as much as it needs to be within HR? And I'm satisfied that it is. The uplift in my voice there is just that I think that's a constant battle to get the balance right between confidentiality and embedded. But I think at the moment we're walking that tightrope very effectively. And the final area is, are the specific cases that Lynn feels that she needs to refer me to, which she consistently does. So from my point of view, no grounds for complacency, but movement in the right direction.
Thank
Chair,
you,
if I may, I have a question for Lynn.
Okay, Joe.
Lynn, thank you for your report. In the context of COVID-19, just two questions. One is, have you started to receive any of people contacting you with anything in relation to that, in terms of their experience? And secondly, going forward in 2020-21, are you planning to, in your discussions and any face-to-face exchanges with people as time goes on, will you also be looking to get feedback and views on what our staff's employees' experience has been in relation to COVID, in speaking up terms?
Thank you very much. Yes, we haven't had as much speaking up in this first quarter as we probably would have done if I'd been out and about with teams. But we've certainly had, I think it's 7 people spoken up in the first sort of 2 months, sort of April and May. And they have raised concerns. It's been more about, in this trust, the issues around getting PPE and about whether ward staff principally are taking social distancing seriously enough, and there has been a tension, I guess, between some people who are very worried about COVID and then the members of staff who realise that a ward is actually perhaps someone's home for 2-3 months, and it's getting the balance right between being completely masked up and being able to give support to people and keeping that 2 meters distance. So there've been a few issues that have been looked into. They've been checked out and fed back, and I think most people have been reassured, and we have managed to address their worries. So yes, we've had it. When I can get back out to teams and start meeting with them, yes, I'll undoubtedly be checking in with people as to what their experience was and what's their voice heard. But I think generally I feel confident that people have been speaking up where they haven't got their answers locally. That's the impression I've got. But I am just about to write today with the comms lead, one of the comms team that supports me, another briefing document for staff, just to remind them. I've been trying to remind people sort of every 2 or 3 weeks that I am here if they have worries and they're not getting the answers that they want.
Okay,
Thank you.
Lynn, thank you very much indeed, and thank you for the annual review, which we note, and the points that you've raised for us. So thank you very much for joining us this morning. So can I draw part A towards close, please? Is there any other business? No?